Hello, my name is Dr. Dan Hindley and I work as a community paediatrician in Bolton in Greater Manchester. This is the second of 3 e-lectures on community paediatrics based on questions from the extensive past test database. I really hope that these lectures will provide you with some insight into the sort of questions that you can expect to have to answer on this aspect of paediatrics for the MRC PCH Part 1 examination. This lecture covers examples of questions about child protection. For this subject, child protection, your learning objectives should be to learn the red flags in the history which may indicate child abuse, to recognise types and patterns of injury suggestive of non-accidental injury, to be aware of pitfalls in the diagnosis of non-accidental injury, and to understand the role of the Child Protection Register and the safeguarding process. This is some of the most challenging work in paediatrics, and adequate training and supervised experience are essential for all paediatricians. You need to be confident in your role within the multi-agency process when undertaking child protection medicals. Question 1. Which of the following statements are true? A. 1 to 2% of children are recognised as being physically abused at some time during their childhood. B. Fathers are most commonly implicated as the perpetrators of abuse. C. Fractures are the most commonly encountered non-accidental injury, followed by bruises and then brain injury. D. All children with bruises suspected of abuse require a full blood count and clotting screen. E. Rib fractures in babies are highly suggestive of non-accidental injury. Child abuse is very common, and A is true. Mothers are the most commonly implicated perpetrators, and bruises are the commonest form of injury, followed by fractures and then brain injury. All children with bruising suspicious of abuse require full investigation to exclude platelet abnormalities, thrombocytopenia and clotting problems. Children under 1 year old who present with bruises that are possibly due to non-accidental injury should be investigated not only with blood tests but with a skeletal survey. And rib fractures in babies are highly suggestive of abuse, although as always it is dangerous to be dogmatic in child protection. So the answers to this question are: A is true, B is false, C is false, D is true, and E is true. Question 2. Aspects of the history relating to an injury that should make one suspicious of non-accidental injury include: A. A history that is incompatible with the injury. B. A long delay between the injury occurring and medical advice being sought. C. A 2-year-old climbing into a cupboard. D. An 8-month-old climbing out of his pram. And E. Ignorance as to the cause of the injury. A and B are classic features of non-accidental injury. Abuse should be suspected when the history is incompatible with the child's developmental status. Vague, inconsistent and varying accounts of how the injury occurred should also raise suspicion. So the answers for this question are: A is true, B is true, C is false, D is false, and E is true. Question 3. Regarding burns in children. A. Most burns occur in school-aged children. B. Burns and scalds as non-accidental injury are underreported. C. There is an association between burns and sexual abuse. D. impetigo may mimic the appearance of cigarette burns. E. Burns more commonly appear on the face of children when abused, as compared with those in whom the burn is accidental. Burns are common in preschool children. Many are accidental, many are preventable. It is thought that there is underreporting of burns and scalds following abuse. Burns can be associated with any other form of abuse, but are particularly known to be associated with sexual abuse. Studies have shown that children commonly burn their head and neck or trunk accidentally, whereas in those abused, the areas burnt more commonly involved the hands, perineum, buttocks or feet. Immersion injuries are highly suggestive of non-accidental injury. The characteristics of this are well demarcated margins, a glove and stocking pattern, and sparing of the limb's flexure creases. Characteristic signs of cigarette burns are approximately 1 centimetre diameter punched out lesions, although occasionally these can be confused with impetigo. So the answers for this question are A is false, B is true, C is true, D is true, and E is false. Question 4. Which of the following signs is conclusive of or very strong evidence of sexual abuse in a child? A. Sexually transmitted disease. B. Enlargement of the hymenal opening to 8 mm in a prepubertal child. C. Patchy localized reddening on the inner sides of the labia. D. Anal laxity or reduction of the power of the anal sphincter. E. Genital or anal warts. Clinical findings rarely provide conclusive proof of abuse. Clinical findings are part of the overall picture and can be helpful. But many children who are sexually abused do not have abnormal signs. The hymenal opening of normal prepubertal girls is approximately 4 mm, but there are individual variations, and an opening of more than a centimetre is usually not seen in normal prepubertal children. Hymenal size alone should not be used as sole evidence for abuse. Patchy localized reddening can occur from local irritation by focal infection, by underwear, or by the child scratching themselves. It can also occur in a rare vulval condition called lichen sclerosis et atrophicus. Anal laxity can occur following constipation or anal stretching for stenosis. Genital or anal warts can be transmitted vertically to infants or be passed on by poor family hygiene as well as by sexual abuse. So the answers to this question are A is true, B is false, C is false, D is false, and E is false. Question 5. Concerning failure to thrive. A. Growth should be plotted for all children attending a doctor. B. Failure to thrive may be a consequence of child abuse. C. All children who fail to thrive have been abused until proved otherwise. D. Is a medical emergency. E. Should be extensively investigated. Failure to thrive is a common problem in paediatric practice. It is most commonly non-organic, but most commonly also not secondary to deliberate abuse. Sequential growth measurements are far more useful than a one-off measurement to determine etiology, and ideally all children who present to a doctor should have their height or length and weight plotted on an age-appropriate centile chart. It's also important to remember to measure the head circumference. Failure to thrive may, in occasional cases, be the sole presentation of serious neglect. Assessment of dietary intake and, in some circumstances, monitoring weight gain in hospital is often all that is required in the first instance. Dietetic advice can be very helpful. If the etiology remains unclear, other possible causes of growth failure, such as cystic fibrosis or celiac disease, should be considered. So the answers for this slide are: A is true, B is true, C is false, D is false, and E is false. Question 6. Differential diagnosis of suspected abuse or non-accidental injury include: A. Osteogenesis imperfecta, B. Clotting abnormalities, C. Scurvy, D. Glutaric aciduria, E. von Gierke's syndrome. Part of the doctor's role in child protection medicals is to exclude any organic causes of injury or illness. And there are many pitfalls that need to be considered. Osteogenesis imperfecta causes multiple fractures, often without a clear history of injury or following what appear to be inconsequential events. Blue sclera and sometimes associated deafness can be signs of this condition. Clotting abnormalities and idiopathic thrombocytopenia can present with multiple bruises of different ages. Scurvy can cause abnormalities of the periosteum and be confused with non-accidental fractures. Scurvy can also be associated with easy bruising. Glutaric aciduria causes bleeding into increased CSF spaces, and von Gierke's syndrome is a glycogen storage disorder that can present with failure to thrive. So for this slide, all the answers are true. Question 7. With regard to the Child Protection Register, which of the following statements are true? A. It is jointly held by the Education and Health Departments. B. Any person who wishes to know the status of a child can obtain this information. C. Children's names can be added to the register after a professionals meeting concerning the well-being of a child. D. All children on the register should have a child protection plan. E. Registration of a child removes parental rights and places these with the local authorities. The Child Protection Register is held by the Social Work Department, which is the lead agency for safeguarding. Names of children are only available to designated professionals, such as child protection teams, which normally include people from police, health, education and social care. Children's names can only be added to the register after a case conference, and at this conference, if children are registered, all children should have a child protection plan put in place. Parents, of course, retain their parental rights and responsibilities despite their children being placed on the Child Protection Register. So the answers for this slide are: A is false, B is false, C is false, D is true, and E is false. Question 8. In which of the following cases does the biological mother lose her parental responsibility? A. Her child is taken into local authority care. B. Her child is adopted. C. The biological father takes over care of her child. D. Her child moves to live with her maternal grandparents. E. Her other children are taken into local authority care. Parental responsibility is held by the biological mother of a child and only removed following adoption. The parental responsibilities may in other situations be shared with the local authority and other parties. Parental responsibility is only conveyed to the father if married to the mother or after the 1st of December 2003 if his name is on the child's birth certificate. So the answers for this question are A is false, B is true, C is false, D is false, and E is false. So that concludes the 8 example questions on child protection issues. The key learning points from this lecture and from your revision on this subject should include an understanding that the history is vital when considering children with injury, that few injuries are pathognomonic of non-accidental injury, but many are suggestive of it. There are many medical pitfalls, and the differential diagnosis for childhood injury is wide. Safeguarding work relies on good recording and good communication of information both within and between agencies, and local policies need to be understood by frontline medical staff. The golden rule of child protection work is to share information and, if necessary, share doubt. There's always an experienced colleague who can discuss difficult or unusual cases with you. There's a lot of useful information now on the Core Info database, which provides evidence-based information regarding child abuse. If you just Google Core Info, you'll be directed to the appropriate website. This is the end of the second Community Paediatrics lecture. Lecture 1 covered child development, and Lecture 3 covers immunisation and public health issues. Good luck in your work.